Today we'll discuss about ocular trauma. A stitch time save nines. Let's see. A stitch in time saves nines means simply just like a stitch in the time infant saves it for more than 1, 2 or 3 months. Ocular trauma approximately 7% of all the body trauma and 10 to 15% in ophthalmology pathologies. Globally, 1.6 million people are blind due to ocular trauma, 2.3 million are bilaterally blind. Approximately 90% of the ocular injury can be prevented. In one North Indian study says 82.3% non-occupational trauma constituted 23.9% case of sports related, and rest are 89.3 case has mechanical injuries. These are the various mode of trauma, just like 24% wood injury, 20% metallic object injury, like this. Now we'll look at ocular injury. Most common ocular injury worldwide: monocular vision impairment and blindness. As per WHO, 55 million people experience serious ocular trauma. The average incidence around in world 3.5 per 1 lakh population, and more than 2 lakh cases occur every year. These are main people which are affected, mainly men and boys, during playing, during outside activities like this. This is the Brigham classification, which is the most accepted in the ocular trauma. It shows two types of injury: open globe and closed globe. In closed globe injuries, contusion and lamellar lacerations, and in open globe, rupture and lacerations. In ocular traumas, early diagnosis and appropriate treatment by ophthalmologists save the eye. Means if we diagnose the patient earlier and treat appropriately, give, if there is scleral injury, we suture the wound, there is corneal injury, we suture, then save the eyes and improve in the prognosis, helps in preserve the vision. Now these are the various forms of injury: foreign body injury, it might be blunt trauma, penetrating trauma, chemical and radiation injury. Chemical and radiation injury has separated treatment course, and foreign body blunt trauma and different course of management. Now ocular trauma is a race against time, means it is a time how early you manage, how early you intervene. Requires a detailed history, clinical examination and radiological investigation for salvages. How we assess? Proper history should be detailed by possible time and nature of injury, which type of injury, blunt, missile, foreign body retained, chemical, etc. Past ocular history, visual acuity, if you have a patient having a recorded visual acuity, rule out any life-threatening injuries, rule out any globe-threatening injuries, examine both eyes, detail examine from lid to cornea, sclera, just like anterior chamber to till retina. Documentation is must, photograph documentation is must. Then we plan for repair. Any structure of eye can be involved, just like we see in previous slide, from anterior to posterior, lid to retina. Any tissue can be involved. Depending on the involvement, damage is there. If not treated, structural deformity, blindness can occur. Now we'll look for principle of management. What are the principles? Basically, we have to restore the injury, restore surgical integrity and preserve visual acuity, repair major trauma under general anesthesia or local anesthesia, whichever possible. Aim of the closure a close as far as possible, except in case of expulsive hemorrhages. Try to identify the extent of laceration and perforation. Try to reappropriate the corneal tissue injury, ocular injury with proper suturing technique. If there is challenging to assess the lens damage, posterior capsule integrity, and therefore plan to manage the subsequent surgery. Just we look in the previous presentation how to manage the foreign body, intraocular foreign body. What are the imaging techniques? X-ray, CT, MRI, USG, OCT. These are the techniques we will plan according the injury, which investigation is better, depending on the involvement of tissue also. Prognosis determined by time taken for the start of treatment, degree of injury, type of eye injury, and prophylactic measure better than treatment. It is always says that prevention is better than cure. So prophylactic management is better than treatment. Now we'll look for grading for chemical injury. This is also known as Roper-Hill's classification. Grade 1, 2, 3, 4. In grade 1, no damage to cornea limbus. In grade 2, cornea is hazy, but iris details are visible. Limbal ischemia is there, which is less than 1/3. In grade 3, cornea is hazy, no iris details seen. Limbal ischemia is 1/3 to 1/2. In grade 4, very poor prognosis, cornea is opaque, limbal ischemia is there, more than half, 50%. Now we'll look for medical treatment. Copious irrigation is first. If there is corneal injury, corneal perforating wound, first we will wash and mat the iris, or we will look for if we can restore it or we can cut out the iris. To restore the normal pH, topical steroid to reduce inflammation, topical and systemic ascorbic acid, topical system citric acid, cycloplegics, topical tetracycline to inhibit glycolysis. Basically citric acid is in tablet, na topical. Role of safety education is, if vision is lost, one become handicapped. So we will look in these cases. Getting a suitable job is difficult. Ocular eye injury is preventable. Onus on clinician to educate patient eye safety. Eye safety is more important than to treat. We will educate the workers or outside workers, wood worker, handlers, like you should prevent this injury by wearing gloves, helmet proper. Primary eye care is having great role. Role of safety education include patient education, worker on eye safety, such as wearing face helmets and safety goggles when working with splashing liquid or flying debris. Mock drill in chemical injuries must. Safety lecture, first aid training is must. Kids sports person to wear safety goggles. Strict protocol should be followed. Now take home message is this: the management depends on time of injury, the need of surgical intervention, and final visual outcome depends on the mode of trauma, time of presentation, extent of ocular damage, time of surgical intervention, and post-operative care of the patient. Thank you.
Thank you, Dr. Harinder.